subspecialty society of this country and fastest growing. And Indian Society of Cornea and Keratorefractive Surgeons have done so well in last few years. And last year we had a growth of almost 300%. And that's the biggest thing possible in any society's growth. And we thank Professor Madan Mohan who started this society. Thanks to you, sir. We are all sitting together in this forum. Professor Mukherjee here, and he's been our past president and main person behind this society to run for so long. Dr. Rishi Mohan, the backbone of the society. We have Dr. Namrata Sharma, the chairman scientific committee, sitting in the audience, and Dr. Rajesh Sinha, the most capable secretary of this country, not only for this society, for the entire country. And future, we hope they do better and better for every society possible in this country. And I welcome you all being a president of this society. And let's hope we have a good discussion. We have few people, but they are one who are important for us, you know. Those who are keen, yes, we'll discuss. Rajiv, you are holding the door. Please sit down. We have some more things to do. We have people who've done a lot of work. They have written books also. And we have a DVD which has to be launched. I'll request Rajesh to start the proceedings.
Okay. Let's start the session, and the first speaker is Dr. Ritika Sachdev, who will be talking on post-LASIK epithelial ingrowth. 6 minutes for each talk.
A very good morning to all of you. I'd like to thank ISCRS for this opportunity to be here. I'd be speaking on uncommon but still encountered complication of a keratorefractive procedure of LASIK, which is epithelial ingrowth. Epithelial ingrowth is basically the presence of epithelial cells where they don't belong, and though it is seen in less than 1% of the cases after primary LASIK, the risk increases about 7 times post enhancement of flap relift. Any factor that hinders the adherence of the epithelium onto the flap or hinders in the alignment or apposition of the flap gives the opportunity for the epithelium to migrate into the interface. It is a good idea to have a thick, good flap, use new blades, avoid epithelial toxicity by the use of excessive medications, and ensure a proper alignment of the flap. Now, not all epithelial ingrowths are as dangerous, so you basically have to grade them, grade 1, grade 2, and grade 3. Grade 1 epithelial ingrowths are only 1 to 2 cells thick and are within 2 millimeters of the flap edge with a well-delineated line and are non-progressive. You may not need to deal with such ingrowths, and you can wait and watch. Some of them are even known to spontaneously regress. Thicker ingrowths, which are more than 2 millimeters from the flap edge, need to be tackled within a period of a couple of weeks. However, an obvious opaque area of epithelial ingrowth associated with irregular astigmatism and changes in the flap needs to be tackled as soon as possible, because these necrotic epithelium cells are releasing collagenase and are going to damage the flap. Now, epithelial ingrowth can have a varying appearance. You see here, you have a sheet-like appearance where the epithelial cells are migrating. Something which is more opaque can also be seen because these epithelial cells over a period of time tend to become necrotic and just become an amorphous mass of cells. So these are two varying pictures of epithelial ingrowth. The patient may be asymptomatic in early cases or may actually complain of significant visual problems due to overlying flap melt and irregular astigmatism. I'll be highlighting the management through a video. So this is the case report of a 27-year-old female who underwent LASIK in 2007 and an enhancement was done in 2008. A flap wash was done in 2013, but when she presented to us, she had a high degree of astigmatism and her best corrected visual acuity was 6/10 partial. This is what the picture looked like. You can see here there is a communication at the flap edge and there's a thick amorphous mass of cells. This really was the epithelial ingrowth that we were dealing with. The anterior segment OCT shows that this nest of cells lies in the interface. The OCT shows an overlying flap melt and the irregular astigmatism is obvious. there is an elevation that comes in due to the mass of cells which lies in the interface. Now, such a flap ingrowth needs to be handled immediately. So, great. What I'll do is, sorry, I'll just play this from here directly. Now, the first is that you have to delineate the flapped edge. You have to lift the flap. You may choose to lift the flap from an area where the flap is less necrotic, because the flap here was slightly necrotic. So the flap is being lifted up. Once the flap is lifted up, please remember that when you're approaching this area, you may have some degree of fibrosis or adhesion, so be gentle. You want to not damage the flap. This cell mass was a little loose because there was a degenerating mass, so this can come off easily. Sometimes you have a sheet which you need to peel off. It is very important to physically remove all the epithelial cells possible, both from the stromal bed and from the underlying surface of the flap. So you see here that you can use Merosol sponge, blunt instruments, to scrape the surface well and remove the epithelium. This is the scraping of the stromal bed that is being done, and the undersurface of the flap. The undersurface of the flap, you have to be a little gentle, but you must make sure that this has been completely removed. Chemical adjuncts like alcohol and MMC have been advocated. We sometimes do use MMC 0.02% for up to a minute. And once that is done, you put the flap back on. To improve flap adherence and to not give the epithelium passage to migrate again, there are three particular techniques that have been used. The first is the use of a BCL. We normally use fibrin glue to really stick down the flap. So this is the application of fibrin glue along the flap edges. This just gives holds the flap down and prevents recurrence of the epithelial ingrowth. Two other techniques have been described, which include suturing the flap in place or placing a tight amniotic membrane by suturing it to the ISCRS so it holds the flap down. So fibrin glue is normally, this patient has already had one episode of removal of epithelial ingrowth. That is the reason we do implant the fibrin glue here, and that is the end of the case. I'll just show the post-operative picture of this patient, and so the post-operatively this patient did fairly well. You see this small area of scarring, but the best corrected visual acuity now improved to 6/6 partial, and there was no recurrence of epithelial ingrowth after that. Thank you for your attention.
Thank you, Dr. Ritika. Any question, any comment on this? What I felt for epithelial ingrowth, it's very difficult to be absolutely sure that you can remove the epithelium completely. There can be some debris, so I guess MMC should be used in all the cases so as to ensure that there's no whatever epithelium is left over also gets destroyed. I mean, that's what I feel, because it's very difficult to absolutely ensure the complete removal of epithelium. Uh-huh.
No, the fibrin glue is like the, we've not had any problem. It stays, you just dry the gutter, because like you saw in this case particularly, the gutter was fairly, there was areas of irregularity in the flap. So you just dry the gutter and it sticks on like a sheet. It doesn't really migrate into the interface. And we've not had any associated inflammation or DLK with the use of fibrin.
I think, it depends sometimes, as she rightly said, what extent and what is the, position of location of these epithelial ingrowths. Sometimes they are very peripheral, as she said, you may not do anything to begin with. But leaving these cells are, really risky for a long term, because ultimately they're going to grow and cause necrosis of entire flap. We have seen patients who had a central, epithelial ingrowth. Vision is quite good sometimes. You like to withhold yourself, especially those patients who have been, operated by somebody else and referred to you. You don't want to burn your hand in that patient because they'll blame your step to manage that epithelial ingrowth where the vision was good. So sometimes you tend to, little conservative. But it is always better to handle these patients as early as possible if they are approaching the, central area. And use of various things can be described, but simple peeling off, sometimes they have a sheet. So you may have to just peel the sheet off from the, either the undersurface or most of them are towards the flap. So you may have to lift the flap and peel it off. That's the best way to take off in toto, rather than scraping them piecemeal-wise. Thank you, Ritika.
Thanks, Dr. Ritika. Next, Dr. Rishi, he has put up his laptop, so I think without wasting his time, any time. Dr. Rishi will be presenting on post-ICL extremes of vault. Dr. Rishi Swarup. Dr. Namrata has requested she has to go somewhere else. If you don't mind, yeah.
The members of ISCRS for giving me an opportunity to present here. So I've been asked to speak on ICL extremes of vault. So as we all know, one of the important measures for proper sizing of the ICL is the central vault, which is defined as the distance between the posterior surface apex of the ICL and the anterior apex of the crystalline lens. An acceptable vault is somewhere between half to 1.5 times corneal thickness, as we all know. Ideal, of course, is about 350 to 400 microns. Anything below below 150 would be considered low, and anything more than 1000 would be considered high. And studies have shown that if the vault is less than 90 microns, the cataract rates are fairly high. The recent model of the ICL, the V4C, which has a hole in the center, possibly has lesser cataract rates because of better nourishment of this anterior lens from the port. Now, regarding subjective measurement of the vault, one has to basically estimate the vault between the posterior surface of the ICL and the anterior surface of the crystalline lens. So sometimes it's not so easy to see, so it's a good idea to just move the illumination from side to side to identify where the lens is, and then you have to basically first focus on the central cornea and then go in and see the gap, the vault there. And if a patient is highly myopic, then peripheral vaulting should also be assessed, especially when the central vaulting is 250 or less, to see if there are any touch points at the optic haptic junction. So if you have a myopic ICL, that's what it's going to be like, and hyperopic ICL, that's basically the shape is different, but the vault is essentially similar. So if you have about half corneal thickness, then about your vault is about 250 to 275 and 1 corneal thickness, and correspondingly you can just see the thickness and decide. You could also use instruments like Scheimpflug imaging or OCT to accurately measure the vault, and that's actually very, very useful. Sometimes you're not able to see and assess very well on the slit lamp, and if you have this tool, certainly it's very, very useful. It's also a good idea to have an idea of the thickness of the ICL itself. Myopic ICLs are between 100 to 200 microns, and hyperopic can range from 300 to 1100 depending on the power, and that also helps in assessing your sizing. So normal vault, like I said, is between half to 1.5 corneal thickness, and it can be variable, and this range is fairly acceptable. But if anything more than 1000 or 1 millimeter is having a higher risk of glaucoma, so it's important that if you do have this, you should do a good gonioscopy after and make sure there's no occlusion of the angles, and carefully watch the IOP, and if that does go up, then you might have to change the ICL or reorient it in some way. So when I talk about reorientation, basically we all know that the sulcus is wider superiorly in the vertical meridian compared to the horizontal, even though the cornea is wider horizontally. So if for some reason your sizing is high vault is there in the horizontal orientation, you can turn the ICL around both intraoperatively and even postoperatively if you see it. Instead of removing and putting in a new lens, you could just turn it by 90 degrees, and often that can fix your vault problem. But if it still doesn't get fixed, then you basically need to change it. A diagnostic dilation is something very useful when you have a high vault, because high vault could be also because of trapped viscoelastic or a pupillary block. So once you dilate, if the vault becomes okay, it means that it's more of a pupillary block or a visco trap behind. If it doesn't, then basically the sizing is wrong, and you'll probably need to fix it, and you might need to do a PI in the current model to help it. So this is what I was talking about, vertically orienting. This particular case, the first eye when I did, the vault was about 900 microns. So when the second eye was to be done, I could have either gone for a lower size, but I decided to just orient the lens vertically, and luckily for me there was also a bit of with the rule astigmatism, which was corrected, and in fact I got a very good result when I did the second eye. Low vaults, less than 125, 150, high risk of cataract and also rotation if it's a toric ICL. So it's probably a good idea to consider exchange. So this is not an ICL, it's an IPCL, and you can see that this has rotated. And this was one of my patients. You can see initially the vault was fairly okay, 150 microns or so, and every 6 months or so the vault started reducing, and finally the central lens was touching the capsule, and we developed a cataract, and this patient eventually needed a removal of the ICL followed by a cataract surgery. So ICL explantation sometimes is required in such situations, and basically you put viscoelastic underneath the lens, especially if the underlying lens is not to be removed, then you have to be extremely careful not to touch the capsule, and you insert viscoelastic underneath and then lift it up. And while removing, the hand over hand maneuver is very useful. So you just grab one haptic, remove it from the wound, and then one forceps on top of the other. And it usually comes out through a regular 2.8 millimeter wound quite well, as you can see in this particular case. I think I've run out of time. Do I have some time? Yeah. So basically, sizing is essentially the main thing, and we all still don't have a proper 100% foolproof method, but I think in my hands the digital caliper is what works best. People have been trying to measure sulcus to sulcus using UBMs, and among the optical measure instruments, I think OpScan is the only one which has been validated by the company, and others we're still trying to find the best one. Thank you.
Thank you, Dr. Rishi. Wonderful presentation. Any comment? Any? Yeah, please.
Yeah, at least a couple of days, because sometimes, you know, various factors can play around, including the pupil and trapped viscoelastic, hydration of the lens, etc.
1,000 or 1,100, you should definitely wait and see.
Yeah. So the vertical sulcus to sulcus is slightly more than the horizontal. That is why you can orient it vertically if it's a tight fit.
Yeah, many times you have rotated the ICL. We have seen even intraoperatively, if you have IOCT, you can see that.
Microns difference in what?
The vertical sulcus to sulcus is more than the horizontal. It's the other way as far as the white to white is concerned. So ICL is normally placed with a meridian in the horizontal one, but if the vault is too high, then you can rotate and the vault reduces significantly.
I think it's important to know what type of post-op results you're going to get in your patient when you put ICL or IPCL. I think last year itself we published intraoperative measurements of ICL position and its vault with IOCT microscopes, and that gives you a real good guideline of extreme of vaulting. Sometimes you can totally flat on the table. No point keeping that IPCL, ICL there. You can remove that or as Rajesh said, you can rotate the lens if it's a too steep one to the vertical area on table, rather than waiting for a few days back or after 1 month, 2 months you're having complications. But that situation is very rare to have a such. So you may have to wait for re-surgery for these patients. For second eye, yes, you always should be very careful. You should, we normally, I personally don't operate both eyes on the same sitting. There are people who operate the same sitting, so you have to manage both eyes then subsequently if you have some problems. I normally wait for a next OT, that is after 3 days. So I know what has happened on our eye which operated first time, so we can measure these by AIOC2017, then recalculate if things are not proper, then decide for second eye surgery rather than going for a bilateral complication happening in these cases. IPCL, as far as I'm concerned, I think there'll be around 3 or 4 years, not more than that. I'm not sure because, Bolt is, I'm not sure because, I don't know if, Siri, you have some experience with IPCL? Because I have done. Okay. Thank you, Siri. I think we'll come to know in future.
Next we have Dr. Namrata Sharma, who will be presenting on post-cataract surgery corneal edema. Yeah. Okay.
I would be talking to you about a very important topic, the management of post-phaco corneal edema. And this is very important.
But he also uses, I use Helon for an intracameral use. So I thought maybe methyl cellulose is getting impacted. So what I did before I inserted my haptics below, I went with my I8 behind the lens to clean the entire methyl cellulose. So subsequently I had a less deposits. No, you can see well.
Meanwhile, by the time Dr. Namrata starts, we can release the book written by Dr. Uma Sridhar.
Uma, please come.
Okay.
कोई फोटो ले लो यार.
आ गया है.
ऋषि, नमस्ते आ जाओ. तुम आगे आ जाओ ना यार. Very nice. Very nice. Odd numbers.
Many congratulations to Dr. Uma for her book. And now we move on.
Mine is jinxed, it's not coming again. DVD भी release कर दिया.
To release a DVD also?
Yeah.
Let's release a DVD also, Rajiv.
Okay. So I'll be talking to you about management of post-phaco corneal edema. And the corneal decompensation can occur due to any surgery which could be related
We have
to
only
cataract,
monocular vision, so please shift to that side.
such as phacoemulsification, SICS, ECC, vitreoretinal surgery, especially in silicone oil filled eyes after vitrectomy or trabeculectomy. Now, the causes could be the preoperative factors. Some patients, they have loose Descemet's membrane or a pre-existent flux dystrophy. intraoperative factors which include surgical or pharmacological trauma, and post-op factors which include topical drugs and post-herpetic endothelitis. And basically the incidence after phaco varies from 0.04 to 0.5%. The intraoperative factors which are responsible for this are the blunt keratomes, the shelved or anteriorly placed incisions, the shallow anterior chamber, or inadvertent injection of saline, viscoelastic or antibiotics during irrigation, aspiration, stromal hydration and IOL placement. And it is important to do a good slit lamp evaluation. The DMD is seen as a discernible translucent layer, and sometimes the corneal edema is so much that you can't actually make out the Descemet's membrane detachment. You may have to put topical glycerine to dehydrate the cornea, and there would be presence of corneal edema with double anterior chamber, and at times even at gonioscopy small peripheral detachments can be picked up. The most important tool for a case which has a post-phaco corneal edema is anterior segment OCT, which adds to the diagnostic value by 30%, and it determines the site, configuration and extent of DMD and guides the treatment method as well as monitors the subsequent treatment outcome. Now, it is important to know the morphology, size and the site of the DMD. Planar is less than 1 millimeter, then it could be non-planar, which is greater than that, and it could have scrolled edges, or it could have rhegmatogenous, tractional or bullous configuration. The conservative treatment consists of the use of topical hyperosmotics, topical steroids and cycloplegics along with anti-glaucoma medications if required, and spontaneous resolution of corneal edema as well as reattachment of Descemet's membrane if it is very small and shallow is known to occur. However, in those cases which don't resolve, the air SF6 or perfluoropropane gas has to be injected, and post-op posturing for the gas bubble tamponade may be required in some of the cases. This is how basically it is done relatively from the clearer area. This is the localized DMD which is present. The pupil has been pilocarponized and a big bolus of air bubble is then injected intracamerally, and you can some amount of the positive pressure is kept there for good 2 to 5 minutes so that the attachment of the Descemet's membrane occurs. And just as you clearing of this can be seen just as the air bubble remains for a prolonged period of time, and as you come out it is important to put some amount of pressure and then come out, because otherwise the bubble comes out. Or alternatively, Dr. Titial has described the use of a viscoelastic bolus of viscoelastic. You can just place it here so that the air bubble doesn't come out as your needle comes out. And this is an intraoperative OCT guided management of DMD. So just as you inject the air bubble, notice that the DMD has become shallow, but it is not quite gone. And if you didn't have this intraoperative OCT microscope, you would probably think that you are done, but actually you are not done. So this is an important, very useful tool in the management of such cases. And just as the Descemet's attached to the back of the cornea, the reflex which is present anteriorly does become clearer. And as you take out the needle, sometimes it detaches again. So one has to be careful, and one has to see that at the end of the surgery, it remains pretty much attached. Now, this is the algorithm that we published, ASOCT guided management for DMD after intraocular surgery. And all the cases which had persistent corneal edema were referred to us within 4 weeks of surgery, and ASOCT was done. And we classified them into planar and scrolled edges, and this is what we concluded, that if the DMD is present in the superior half and is planar, then air works well, but if it is inferior, whether planar or scrolled edges, and if it is in the superior half with scrolled edges, then it is useful to use SF6 or C3F8. And these are some of the pictures of the same to show how it resolves with the use of the gas or the air. And it is important to know where you are going to put the air or the gas, because if you put it in the red arrow, then you will actually increase the scroll, but if you put it near the green arrow, then it will cause the attachment of the Descemet's membrane. Repeat desmetopexy can also be done after cataract surgery, and sometimes you actually have to put sutures, because the Descemet's membrane is so taut that after repeated injections also it doesn't get attached. So you have to actually apply sutures to the taut Descemet's membrane, and the air injection has to be on for good again 2 to 5 minutes. We've also published this paper on subclinical incision site DMD after phaco, where we did see that although it may occur at day 1 and day 7, in almost over 100 cases, but over a period of time it does resolve. One more thing that is very important for a case of post-phacocorneal edema is the herpetic endothelitis, which gets triggered after phacoemulsification, and these are just examples to show you the same. There's a localized corneal edema which is present here, and after you treat them actually with topical steroids and with systemic acyclovir, it does get resolved. And this is a more drastic case which came referred to us for keratoplasty, but resolved just on medical therapy with topical steroids and systemic acyclovir. And likewise this third case. So one has to be always keep that in mind, that there could be triggering of the herpetic endothelitis following phacoemulsification. Now, of course, if all else fail, then one has to do a DSEC in these cases eventually, and the posterior lamellar lenticule is injected intracamerally, followed by the injection of the air. And collagen cross-linking can also be done for these cases, but this is a temporary procedure because the corneal edema comes back over a 6 months period. And another thing that is probably going to play an important role is the pharmacological treatment, that is the ROCK inhibitor or the Rho kinase inhibitors. And trials are going on, and if it works well, then probably we'll have a pharmacological treatment for corneal edema. So to conclude, slit lamp evaluation and AIOCT should be done in all cases where corneal edema doesn't resolve. Treat pharmacologically in those cases where the DMD is shallow or where there is a chance that it may get resolved spontaneously. But if it is present, then pneumodesmatopexy is required. And if DMD is absent and despite this the persistent corneal edema is present, then you may have to do a endothelial keratoplasty. And do not forget that herpetic endothelitis can trigger in such cases, and it should be treated appropriately. Thank you for your attention.
Thank you, Dr. Namrata. Next we have Dr. Sri Ganesh, who will be presenting on retreatment in SMILE.
Good morning, dear friends, and I'll be talking on retreatment in SMILE. Enhancements after SMILE are fairly rare. I've done about nearly over 5,000 cases of SMILE, and I've enhanced about 5 of these cases only. So the accuracy of and predictability is quite good, but nevertheless there is a chance that you may have to enhance the results. So let us look at the options. I am a consultant for AMO and Zeiss. Options are, you can do a surface ablation like PRK, or you can do a LASIK by actually making a side cut and converting the cap into the flap. Only thing is the cap is quite small. It's just like 7.2 millimeters, 7.5 millimeters. So you'll get a small flap, and especially for hyperopic corrections it is not good. Then you have the circle software where you can actually convert the cap into a larger flap, and this is something that is being used now. Then the last option is whether you can do a re-smile, a smile on a smile, and this is also possible. It was described about a year ago by David Donate in France, and I have done a couple of cases, and it's been quite successful. I'll show you the video also. So coming to surface ablations, it's the simplest procedure, very easy to do, ideal for very low enhancements. Typically the enhancements are very low, 0.5, 0.75 diopters. But here you have to take epithelial thickness into consideration if you are doing trans-PRK. And I prefer to use mitomycin for about a minute because the incidence of haze is much more after SMILE. And the advantage of PRK is that you maintain the flapless procedure for the patient. But you can see that this is one case where we had a little bit of haze. So this is something that can happen even if the enhancements are very low, 0.75, 1 diopter. That's why I like to use longer duration of mitomycin C. LASIK can be done with thicker SMILE caps, 135 microns or more, and for low enhancements. Again, epithelial thickness to be taken into considerations, and you can do a re-flap on a SMILE. If you have a very thick cap like 160 or more than 135, you can just do a flap the regular way you are doing it. Or you can make a side cut like I told, but there is a risk of, when you make a re-flap, the complete flap, there is a risk of entering the previous interface, especially if you are using a thicker flap. And the hinge has to be placed away from the SMILE access incision. You have the circle software which is an enhancement solution for smile. It allows a surgeon to convert a smile cap into a large flap, and you have a lot of options for planning and creating incisions. Basically, you have the lamellar ring here, which you can decide the length, and then you have the side cut with the hinge, and then the junction cut. So I'll not go into the dimensions, but the inner diameter of the lamellar cut should be approximately smaller than the existing incision. The overlap should be large enough to reliably cater for tolerances in size and length of existing incision and in the position of the eye on the contact glass. The upper and lower depth of the junction cut should be chosen so that the depth range at the edge of the existing incision should lie, taking into account the positioning tolerance. Anyway, this is the software which comes on the screen, and you can select what kind of mode you want and the dimensions and enter it before doing the treatment. There are different patterns for a circle treatment. This is how you can vary the junction cuts. So there are some risk zones which you will have to take into consideration, where the hinge overlaps the previous incision, and you should be careful, otherwise you can get almost like a free flap. So that is, I'll just show you a video of the procedure of the circle procedure. This is you dock the eye with the Visomax, center the treatment, patient fixation, and then once you activate the foot switch, you have the circle software there, and then you have the hinge, the 270 degrees cut and the hinge. After that, it is just like lifting a regular femto flap. You can see that here I am using the reverse side of a Siebel's. Open up the side cut there. Then you go into the interface. See, that is the interface. And once you have gone into the interface, then you can lift the flap very easily. There's a little bit of resistance at the side cut. This was a hyperopic cylinder which I had to enhance. You can see that this is the side cut of the smile, and this is the new side cut of the flap. So this is the bed. So then you can use the excimer laser and do the treatment. So the only disadvantage is here you are converting from a flapless procedure to a flap procedure. Okay, that's the ablation, but we'll just keep that for. And then you put back the flap and settle it as you normally do. Smile on smile, I'll just take one more minute. Can be done if you know the previous cap thickness, can be used for higher refractive enhancement if it's more than 0.75 diopters. Epithelial thickness to be taken into consideration here also. Here there's an advantage of maintaining the flapless procedure, and after the refractive cut and the side cut, you put off the suction and you go in through the original axis incision. The old interface is in the superficial plane and can be easily opened up. The deeper plane is dissected carefully, and then the lenticule is extracted. Minimum thickness should be maintained for a good energy level and easy dissection. You can add 25 to 30 microns for this, and residual stromal thickness also should be adequate for the procedure. Centration is critical. So this was a patient. You can see the pre-op topography, and this is the post-op. This is the difference map after the enhancement. This was 1.5 diopters. So this is the video. So this patient had undergone smile monovision, didn't like the monovision, so I did the enhancement, 1.5 diopters. So after docking, you can see I make the refractive cut. This is a spiral in cut, and after that there's a side cut, Immediately after the side cut, you put off the suction. You lift your foot from the foot pedal, put off the suction. Then you can go in through the same axis incision. That's the axis incision, 2 millimeters. Here I am trying to find the deeper plane. It easily enters the superficial plane because that's the original interface. You go to the deeper plane, and I'm using a Reinstein dissector here, and then you can dissect the lenticule, because this is something that people say you can't do a smile after doing a smile, but you can do it. I have done a couple of cases successfully. Of course, the company does not have an official software for this. You have to manipulate the laser and put out the suction and do it, but it is possible. Once you dissect the deeper plane completely, then the superficial plane you can see is open. You can see it doesn't need dissection, and then once you know that the lenticule is free, you can either use a microforceps or just pull it out with the same incision. It comes out easily. And this patient did quite well. The refractive correction also is fairly accurate. So this is one more option which is there. So these are the options for retreatment of smile. Thank you very much for your attention.
Thank you, Siri, showing a nice way to handle smile, post-smile refractive residual problem. Thank you again.
Thank you.
We have now Dr. Rajesh Sinha, who is going to talk about, I think, one of the important way to handle post-CXL patients, various options. Rajesh.
Thank you, sir. I'll just try to be very brief in that due to paucity of time. I'll be talking about post-CXL management of keratoconus. The basic idea of doing CXL is to stabilize the cone, and if it stabilizes, then we have to provide refractive rehabilitation, refractive correction, and that can be given by glasses in very early cases, or contact lenses, or ring segments, or ICLs, and there are some other options as well. Sometimes it progresses, and some people have tried retreatment. Now, retreatment usually should be attempted only after 1 year with a proper documentation of the progression. In some of the studies, in a few studies, they have shown additive flattening, and there was arrest of progression. In one study, they showed there was no improvement at all. So perhaps repeat CXL is something which is still being evaluated, and we may become wiser with time after doing repeat CXLs. Once the cone stabilizes, we have to provide contact lens rehabilitation. Now, contact lens should be prescribed. There are various options, but the most important is rigid gas permeable contact lens. Contact lens should be prescribed after 2 to 3 months after CXL, once the surface stabilizes. Preferably 3 months, but it can be provided, given after 8 weeks as well, because these patients are very much dependent on contact lenses because of very high refractive errors. The options are bicurve Soper designs, multi-curve Rosquet designs. The end point of fitting is good centration, movement and coverage, and a 3-point touch. This is the dynamic fit. I would skip that and go to some others. Piggyback contact lenses are rigid contact lens on soft ones, and they are given in those who are intolerant to RGP contact lens. Contact lens can be associated with, keratoconus can be associated with PMD, and in those cases, hybrid lenses as well as miniscleral contact lenses are quite useful. Now, intracorneal ring segments are again quite useful to correct the astigmatism. Now, as far as the surgical plan is concerned, we have to convert the cylinder into plus cylinder form and see what is the axis, and then the radial incision is made at the axis perpendicular to it. So here, plus cylinder at 160 degrees here, so the radial incision is made at 70 degrees so as to implant the intacs in the two axes. This is just because of paucity of time, I will just go very fast. Femtosecond assisted implantation of intracorneal ring segment. The suction ring has been placed, the applanation cone has been placed, cornea has been applanated, and then the femtosecond laser will be fired. So the tracks have been made, and this is the radial incision, which is opened first, and then the tracks are also opened in order to initially so as to put the ring segment inside, and then and then we put the intracorneal ring segment in its position. Both the ring segments are placed, and then it can be combined with CXL. It can be done after CXL as well. This is the first post-operative day, the AIOCT picture, and in some cases they have high uncorrected refractive error still after the intact. The astigmatism is corrected, but high myopia is there. In such cases, we can give a mini-scleral contact lens for rehabilitation. Toric ICL is another option. I'll skip the video. If the cone is stabilized, we can implant the toric IOL. People have done topo-assisted surface ablation in order to smoothen the surface. The idea is not to correct the refractive error fully, but to make minimize the irregularity of the cornea by the ablation, so as to improve quality of vision and to improve contact lens fit. Lenticule implantation has also been tried. Dr. Sri Ganesh is here. He has tried FILI, which is femtosecond assisted intrastromal lenticule implantation, and that has worked well in his report of 8 eyes. We have also started using bioengineered corneas in our center, RP center, and implanted intrastromal these lenticules, and this is a little early to make a definite statement, but maybe with time we will become wiser. And keratoplasty is the last resort in order to handle the keratoconus if it's not stabilizing, and the anterior keratoplasty as well as full thickness graft if there is a scar present. Thank you very much.
Thank you, Rajesh. Just I'd like to add just one thing, before doing a procedures or a contact lens rehabilitation post CXL, you have to give us some time for a cornea to get into a normal shape. Maybe around 3 to 6 months people wait. We have done a contact lens post CXL series where we waited for 6 months in these cases, where then subsequently went for rose scale lenses for these patients. Because the cornea keeps remodeling after CXL for a very, very long time. And even after 6 months, we had an initial 3 to 6 months post-contact lens, the cornea was remodeling itself so much. So you require a frequent change of contact lenses in these patients. That has to be explained to the patient. If you're going for rose K type of lenses, you always go for exchange lenses so that patient bears less cost to these categories. Same thing holds true for a topo-guided ablation in these patients. There also we wait for 6 months before we take them for a topo-guided ablations. And the series we have done seems to give a very good results. In a moderate amount of refractive error post CXL cases, they have a very good vision. But you have a very high irregular astigmatism, a lot of corneal aberrations, then these patients also do well subsequently after ablation. Then you can fit a contact lens so that they do very well. And now we go to the next talk, which is another interesting talk on a viscoelastic assisted DALK in a difficult situation like post-RK patients. Rajiv, please.
Good morning. Thank you, sir, for allowing me to present at the session. I'll be presenting this case where RK was done ages ago and the patient eventually developed corneal ectasia. Right. So the video. This is the case where RK was done. There is a very different technique of doing DALK described by Subota from Japan, the divide and conquer technique. We've just trephinated the cornea very superficially, maybe about 200, 250 microns, and the idea is to debulk the superficial cornea. So what we have done is we are using a lamellar dissector. This is the Pufex knife. As you can see, we are passing from one end of the cornea to the other. Making a small trench, rather a plane, at a very superficial plane. And next we're going to use the Vanna scissors to split this, use this trench to divide the cornea into two halves. Eventually, using the same Pufex knife, we're going to divide these two large pieces of pies into 4 pies, and thereby what this does is safely allows us to debulk the anterior stroma completely. So this is the Vanna scissor. So we've just split up the superficial anterior stroma. And again, using a lamellar dissector, the Pufex knife, you can use any thin crescent blade which is long enough to go and pass through the whole cornea. And again, go up to the edge of the trephination use the Vanna scissor again to divide, and what we have achieved now is 3 pieces, and do the same on the other side, and eventually just dissect out, not trying to be too meticulous with the dissection, the superficial stroma. So we have essentially debarked the anterior stroma completely. The next step would be to do a paracentesis and put in some air, which will actually be a guide to the Meles technique that I'm going to use to reach a desirable plane of dissection. This is again the same Pufex knife. I would like you to appreciate the distance between the internal reflex that I just showed here on the video and the tip of the keratome. The idea is the closer you are to the internal reflex, the deeper you are. It is said that you are at 98% depth when it just approximates the tip of the keratome. And this is the period of time when I realize I'm almost approximating or touching the internal reflex. So this is where I would like to stop and just deepen the tunnel internally, not deepen, rather extend it in the same plane, making sure that the neck of the tunnel is not enlarged. This is the same tunnel that we are going to use to inject viscoelastic. Idea is if we enlarge the neck to be wide, there will be egress of viscoelastic, and you won't get a good adequate dissection of the posterior stroma. So here you have the viscoelastic agent being injected, and you can see a bubble being formed there, which is a viscoelastic bubble, which is separating the posterior stroma at a very deep level from the anterior stromal fibers. So at this point we also need to be very careful because the intraocular pressure might and will certainly increase. So we are digitally keeping a watch on that. So we go to the edges. You can see there that we have reached the edge of the trephination, and we'd like to burp out some air at this stage, knowing very well that the pressure is high, to normalize the situation. And you can see the sausaging of the air bubble. This is exactly gives us a good clue that the posterior stroma has been pushed back. We use the Vanna scissors to just split the freshly dissected anterior stroma and again convert it into 4 pieces of pie. And this is the stage we have to be very careful and very slow at times and meticulous that we do not touch the Descemet's membrane that's left behind. There you can see this shining Descemet's membrane with the air bubble now coming into the center from the periphery. I find this very predictable and safe, especially in difficult cases that you saw just now, like post-RK corneal ectasia. This is donor cornea, optical grade that we used to use in those days. This is a case done in 2005, I think, 4-5. So we strip out the Descemet's membrane from the donor cornea. I used to have an optical grade to perform these cases, just in case we had a perforation. So you see the endothelial stripping. I mean, nowadays seeing this video, people doing DMAC would be horrified that it's a waste of a tissue, very viable tissue. But we just stripped out the Descemet's membrane over there and used the whole entire cornea with the stroma, Bowman's and the epithelium, and regular suturing would be the answer. I'd like to skip the rest of it in interest of time. Just dry out. That's it. Thank you very much.
Thank you, Dr. Rajiv. Next, we have Dr. Tityal, who will be talking about the lenticule management in anterior chamber in DSEC. We had electrical failure for twice, sir. So just 5 minutes.
Yeah, thank you, Rajesh. I will briefly take you the important aspects of managing air in endothelial keratoplasty. You all know air has a huge role in managing in all these steps, right from the descendant membrane scoring to a graft unfolding, graft orientation, graft centration, and ultimately graft apposition, and that is intraoperatively, and also you have a post-op management with this. So let me take you on the graft apposition. You know that graft apposition is one of the most important aspects of DMEC or DSEC surgeries, because post-op dislocation or decentration of graft is managed by this. So before I normally do all DSEC or DMEC cases, peripheral iodectomy inferior I do routinely for all my cases, and this helps you to manage the air bubble nicely at the end of surgery. So that is a very important aspect of surgery here. If you look into insertion of graft, once you Descemet score, you know that entire Descemet has scored very nicely. The graft normally flows in the DSEC very nicely in the antechamber. Then subsequent air injection will push the graft to the center. But make sure your orientation is centralized and you have a space between the graft and the AC in the iris plane. So once you inject the air bubble, you know that little decentered, that little tucking from the superior side will cause graft to get centered. The idea to show this video here is the AC should be more oftenly filled with a air bubble rather than a fluid. Once you have a fluid, the centration of graft becomes very, very difficult here. The same thing if you see here, normally I'll say flatten the anterior chamber as much you take out the fluid beforehand, before you inject the bubble. And inject a bubble just underneath the graft here. You can see the graft is half oriented here, peripheral is still tucked, irregular. And this tucking is improved by injecting air towards that side so the graft can be centered or flattened accurately in that area. Maybe a little bit of tuck from superior side will also handle the graft very nicely. Sometimes you have a graft and air bubble in the interface, and this is very difficult area sometimes, very difficult to take out these air bubbles. What I do normally, I go little peripheral, inject bubble, keep injecting from center, then keep a massage from anterior side. So if you have more of air, no fluid, then this air bubble from interface also goes off very, very fast. And sometimes when you have difficulty, you inject the bubble very, very fast, the entire graft gets to one side. And this normally happens when you're injecting with a lot of force. And once graft goes to the angle area, it's very difficult to undo it, because the graft is already attached, and the peripheral portion is not available for pushing it back to the center. So if that situation there, you have to physically move this graft to the central area. So what I'll do, I'll use a needle here and let the graft come to the center with your force. And release the bubble and pressure first. Put a small bubble, then center it with the needle. Because unless you see the peripheral edge, it's very difficult to center the graft. And that clarity of mind should be there on table. It's not possible here, then I'll use physically, I'll rotate the entire graft with the needle. That can be done in DSEC very, very nicely. It's not possible in DMEC procedures. So once you center it, the things are very, very simple here. Then how much time you require graft to get attached in these cases? This is our publication telling how it normally happens. And we saw that to make sure that graft attaches very fast, we made three groups. In one group, we kept the air bubble for 8 minutes, and nothing happened in 8 minutes. The graft didn't get opposed. In other group, we made an external massage with internal pressure. If you see here, we just waited for 8 minutes, then we had to subsequently massage this and to get attached. In one group, we started massage right from the beginning. The graft got attached in less than 2 minutes. So that's enough time for a graft to attach, and we waited for 5 minutes more. In 7 minutes, the surgery was over. So you don't have to wait really for a long, long time for these patients. One video I'd like to show for our post-op management. In these cases, you can have a pupillary block. And to manage pupillary block is very difficult sometimes on table, on the slit lamp. People have described that. You can see I have almost 360-degree peripheral anti-synechiae, though central bubble is there. And graft is very, very thin in this case. And you have to be very careful not to damage the iris when you're making a puncture. Maybe a partial puncture will do. Subsequently, take a cannula which has a little bit of a fluid. Go to periphery first and flatten the iris. Don't go to the center and come back, because peripheral attachment is very difficult to release. First, you have to release the peripheral attachment, then go to center. So once I release the peripheral attachment, the iris diaphragm goes down from the angle area. But if you release the central area, the peripheral angle is very difficult to release. And that is very important point. And subsequently, you can make, I have made two PIs here, one superiorly, one inferiorly, so that subsequent this floppy iris doesn't cause attachment. So once you have a iris which is floppy, it keeps on coming back to the same position. So apart from forming the chamber, make sure you do a peripheral iridectomy in these patients. The rebubbling is quite important to be assessed in the post-op period. You can do AIOC to see your patients. Sometimes there are fluid pockets rather than the entire graft getting detached, and these pockets will extend subsequently to cause a full detachment. Especially if you have a central pocket that has to be managed, it doesn't go off. If you have a little bit of peripheral detachment, it might get attached. So that is a very important point in the DSEC and DMEC cases. I would say air has a very important role in endothelial keratoplasty, right from the initial step of scoring to the final stage of apposition, and subsequently, if you have a post-op problems, also air is required in these cases to manage. Thank you for your kind listening, and I would say thank you for coming for this morning session for our sub-specialty meeting. And Indian Society of Cornea and Keratorefractive Surgeon is, as I said in the beginning, one of the fastest growing society in this country. And we have had a wonderful annual meeting last year. This year also we are going to have annual meeting in the month of August, that is 12th and 13th, Saturday, Sunday in Delhi, same center. The advantage of this society is placed in the capital of this country, and every time the meeting is going to happen in Delhi only. And Delhi has the largest base for interconnecting from the different cities and different countries. We have large number of international faculty coming this time with all the facilities which you see in mega conferences, right from the wet lab, live surgeries, skill transfer, and a lot of experienced faculty and support of our senior members. And this society is doing very well, and I hope all of you will attend this meeting, annual meeting of ours. We have members from every part of this country, and we are hoping for some more regional meetings in future. Rajesh, for a conclusion.
Thank you, sir. Before we end the meeting, this session, I would request Dr. Kuresh Maskati and Professor Radhika Tandon to join us in releasing the DVD on meibomian gland dysfunction. I would also request Rajiv to come over.
Please, all the delegates collect breakfast here.
This DVD is from the ISCRS, and it contains 1 hour of lectures on meibomian gland dysfunction entirely. So it's entirely dedicated to MGD. Please take this. It's available at the stall from CIPLA, who've been very kind sponsors for this effort of ours. So please collect it from them.